All right,
All
guys, we're
right.
going to get started. Austin's going to be talking today. I'll make sure this gets posted to the YouTube page so you guys can reference at a later date, and Kelsey can then dial in. This was Austin's fellow talk, so it also gives you a good idea of in the spring, we'll have you each pick a topic and try and pick something that is relevant to CAQ prep so that you kind of bolster your knowledge up before taking the test. So it's a good example of kind of one of the fellows talks we've had in the past. Thanks for your time, Austin.
Yeah, thank you. Yeah, so this was my fellow talk. Just as frame of reference, I used the AMSSM CAQ review, that green book, kind of as my background and kind of templated my lecture based on that. Since then, I last year went back through this lecture a little bit and highlighted what I remembered seeing on my CAQ. I talked with Suze again earlier this week about what she recalls because she's taken it a little bit more recently than I did. And then last night went through again and highlighted a couple things that I think are important. So some of this is very dry. Well, a lot of it is very dry, just kind of background, mechanism of action of medications, etc. So bear with me. And so there'll be some slides that I kind of skim through and we'll kind of focus on the highlighted stuff. So this lecture is on pharmacology and doping in sports medicine. Some of the objectives: identify common medications used in sports medicine, review MOA, safety profile, indications, contraindications, discuss pharmacology's role in optimizing athlete performance, identify common PEDs, and discuss their impact on performance, review WADA guidelines and anti-doping screening, and then discuss the ethical implications of doping. Again, condition-specific medication regimens are not included in this lecture. There is a whole separate chapter in the AMSSM book that goes through that, but I even found that not actually to be that helpful, so I think it's more learn as you go through your questions and everything. All right, let's dive in. So analgesics, just most common analgesics that we see prescribed: acetaminophen, opioids, and tramadol. Acetaminophen, obviously, big hot topic in the news lately. Don't believe what they tell you. That's all I'll say. Mechanism of action. So the exact mechanism is unclear. It might elevate the pain threshold, might inhibit or affect inhibition of nitric oxide pathway mediated by neurotransmitter receptors and N-methyl D-aspartate and substance P. It accomplishes fever reduction by inhibition of endogenous prostaglandins in the central nervous system. Again, this is one of those examples that was highlighted because I remember this coming up in my CAQ review and or on the exam. At this point, they're blurring together. Little to no anti-inflammatory effects. So it's a first-line agent for mild to moderate osteoarthritis, used by ACR, AAOS, and the American Pain Society. It's also a first-line agent for medically complex patients. So for American Geriatric Society for mild to moderate musculoskeletal pain in those over 50. AHA has approved it for those with cardiac conditions or risk factors, and the National Kidney Foundation for those with underlying renal conditions. Also used as treatment for temporary relief of minor aches and pains associated with common cold, headache, toothache, muscular aches, etc. Superior GI safety compared to NSAIDs. Contraindications. So chronic alcoholics might be at risk for liver disease, but there are conflicting reports. It's reportedly safe in chronic stable liver disease, but again, some conflicting evidence. Overdose in conjunction with taking anticonvulsants might increase risk of liver injury, and high caffeine intake might also elevate risk. Recommended maximum daily dose is 3,000 milligrams per day. Some European countries go up to 4,000 milligrams per day. Opioid examples: so codeine, Demerol, hydrocodone, morphine, oxycodone, and fentanyl. So mechanism of action is to bind opioid receptors, primarily mu, kappa, and delta. Has central and peripheral nervous system effects. Codeine conversion into morphine in the liver is dependent on cytochrome P450, so it might not be efficacious in some populations. Again, this is another thing that I saw pop up, is that codeine's conversion is dependent on cytochrome P450. Propoxyphene adds little anesthesia to acetaminophen, has been withdrawn from the market in the US, but is available in Australia. Indications for opioids: moderate to severe pain, cough, and diarrhea. So codeine can be used for cough, loperamide can be used for diarrhea. Contraindications, you'll notice a theme as we go through these contraindications: any history of hypersensitivity or allergy to the medication. I feel like I'm kind of rambling like one of those commercials where they say, if you've ever had any allergy to this medication, do not take it. So as we go through, you're going to see that that's a common theme going through. Concern regarding combination medications, so acetaminophen toxicity or liver injury. Obviously, there's a risk for dependency and addiction. Drug testing might limit use of opioids, which we'll kind of get into later in this lecture. And then I have the relative potencies listed out here. And again, I'll send this lecture over to Suze. I did provide a few updates just so you guys can kind of go back and reference this, but you don't have to have this memorized right off the bat or anything. So mechanism of action for tramadol, it's a synthetic analog of codeine. It has a low affinity for opioid receptors, but its primary metabolite has a high affinity for opioid receptors, only partially inhibited by naloxone. And norepinephrine and serotonin reuptake inhibition is also part of the mechanism of action. It's available as combination medication with acetaminophen. Indications: moderate to severe pain. Precautions, this is an important one. So taking tramadol and selective serotonin reuptake inhibitors can predispose to serotonin syndrome. So something to keep in mind if you're looking for other medications to treat for pain, but patients are on SSRIs or SNRIs or any combination of the two, that I would proceed with caution or probably just avoid it in general. So antibiotics, really just two classes that are emphasized through AMSSM's review. So penicillin and its derivatives, and fluoroquinolones. So penicillin weakens the bacterial cell wall by inhibiting formation of peptidoglycan crosslinks. Little research on athletic performance. It might be overprescribed for elite athletes for non-bacterial conditions. I'd say that it's overprescribed not just for elite athletes, but also the general population. Many athletes fear adverse side effects, so GI side effects might impair performance. Fluoroquinolones, its mechanism of action is to inhibit bacterial enzymes responsible for DNA replication and transcription. So contraindications: any known hypersensitivity to this medication, any central nervous system conditions such as epilepsy, stroke, or meningitis, any history of prolonged QT syndrome, and for children, there's a risk for growth plate injury and tendon rupture. So those are all important things to remember when you're going through your review. Risks: so it may cause tendinopathy or spontaneous tendon rupture, particularly in the over 50 age group and in any patients taking corticosteroids. So anti-diabetic agents, so most common anti-diabetic agents that we see are insulin, thiazolidinediones, sulfonylureas, meglitinides, and biguanides. So insulin inhibits intracellular lipase that hydrolyzes triglycerides to release fatty acids, facilitates entry of glucose into adipocytes, and the synthesis of glycerol in those cells, delivered through subcutaneous injection. So pre-exercise injection should not be in the region of primary muscle being exercised, for example, into the thigh for a cyclist, due to increased uptake, which may lead to hypoglycemia. That's definitely something to remember. Multiple formulations with different onsets and durations. So just different insulin types, their onset, their peak, and their duration of action. So you have the rapid acting all the way up to the long acting, ultra long acting. Indications for insulin use: those with type 1 diabetes or insulin-dependent diabetes, and patients with poorly controlled type 2 diabetes with oral hypoglycemics, diet, and exercise. Contraindications: if there's hepatic disease, renal disease, or renal impairment, hypoglycemia and hypokalemia, and then any history of insulin hypersensitivity. So hypoglycemia and hypokalemia, those would be two. Sorry, the light keeps going off in my room. Two important things to kind of remember. I would guess that our ER docs remember that a little bit more than those in family med, just because I feel like they see it a lot more in the ER. But those are two contraindications that are common. So risks or side effects: low blood sugar, weight gain, bronchospasm with inhaled insulin, sustained nausea and vomiting is a sign of insulin allergy, and a skin rash or lesions at the injection site. Insulin might be used to enhance performance since it has similar anabolic effects to insulin-like growth factor when taken with glucose. So next class, thiazolidine diones. The complete mechanism is unclear, but it lowers insulin resistance. So pioglitazone reduces triglycerides and increases HDLs. Rosiglitazone increases HDL and slightly increases LDL, generally not a first-line agent for diabetes management. Risks or side effects: so upper respiratory infections and sinusitis, headaches, anemia, fluid retention, which may lead to congestive heart failure. I remember this being a common one, kind of noted in my primary care practice and also on family med boards. I don't remember it as much along the CAQ studying journey, but I know that it's an important thing to keep in mind. Weight gain, muscle pain, increased risk of fracture in women, and possible risk of liver damage, particularly seen in the older class of medications or older medications in the class. Sulfonylurea, so it increases the amount of insulin produced by the pancreas. So you have to have a pancreas that is competent in producing insulin to take sulfonylureas. Combination medications contain metformin and decrease the amount of glucose produced by the liver. There's long-acting, and then dose adjustment might be necessary to prevent hypoglycemia during competition or training activity. So some of the examples are glipizide, glyburide, and glimepiride. Risks or side effects: so any history of sulfa allergy, cross-reactivity, teratogenic, so do not take while pregnant or if trying to become pregnant. Unsafe if liver or kidney problems, as it's metabolized by the liver and excreted through the kidneys. Alcohol increases risk of low blood sugar. Hyperinsulinemia might lead to increased cardiovascular disease and may also cause weight gain. Glitinides, so these are novel agents, increase the amount of insulin produced by pancreas similar to sulfonylureas. They're faster acting with a shorter duration. Repaglinide and nateglinide. Risks and side effects: may not be safe in pregnancy, similar side effects to sulfonylureas, and may not be safe in liver or renal disease. Bigonides, so not completely understood, that this is one of the most common medications that we see prescribed for non-insulin dependent diabetes, so metformin. It decreases glucose production in the liver, increases glucose absorption in muscle, and decreases insulin resistance. Metformin is the most commonly used anti-diabetic drug in the world. It's considered first-line agent in type 2 diabetes when diet and exercise alone are not effective, and it is not associated with hypoglycemia. Risks or side effects: nausea and diarrhea are the two that I've seen the most common in my practice. There's loss of appetite, increased abdominal gas, metallic taste, rarely lactic acidosis during exercise, but this may limit use in athletes. So higher likelihood if liver or kidney problems exist and is associated with dehydration. It's contraindicated if there's renal impairment with creatinine over 1.4. Other indications for metformin or bigonide class of medications would be PCOS, non-alcoholic fatty liver disease, and premature puberty. So antihypertensives, I'm going to take a little break here to just take a sip of water. Sorry if I'm talking a whole lot too. If you guys have any questions, feel free to stop me, just to ask as we go along. But common antihypertensives that we see used: calcium channel blockers, ACE inhibitors, ARBs, diuretics, and beta blockers. So JNC8 recommends initial use of a thiazide diuretic, calcium channel blocker, ACE inhibitor, or ARB in the general non-Black population, or a thiazide diuretic or calcium channel blocker in the general Black population. That's something important to remember, not only for general boards, but also for the CAQ. So again, I tried to highlight all these, so when you guys are kind of last minute going through this lecture, if you decide to reference it again, I would focus primarily on everything that I have kind of highlighted, underlined, or italicized. So calcium channel blockers, they block L-type calcium channels, which relaxes vascular smooth muscle, dilates the blood vessels, reduces peripheral vascular resistance. Dihydropyridines have a greater affinity than non-dihydropyridines. Specific to non-dihydropyridines, they decrease myocardial contractility. So this is your diltiazem and verapamil. And they slow the heart rate and decrease cardiac oxygen requirements. Indications are hypertension, angina, and abnormal cardiac rhythms. That's going to be more your non-dihydropyridines that you'd see more used for the abnormal cardiac rhythms. Contraindications, so verapamil and diltiazem reduce heart rate and strength of contraction, so might not be the best choice with CHF or use in athletes. Amlodipine, one of the dihydropyridines, has little effect on heart rate, so poor choice if treating an arrhythmia, but is a good choice for use in athletes. One thing to consider with that would be fluid retention. That's a common side effect that we'd see with that. Risks, side effects, so verapamil and diltiazem decrease elimination of many drugs by the liver. Grapefruit juice might elevate concentrations of some calcium channel blockers. Common side effects include constipation, nausea, headache, rash, peripheral edema, and hypotension. ACE inhibitors, mechanism of action, it inhibits ACE. That's pretty self-explanatory. Decreases production of angiotensin II, which leads to dilation of blood vessels and lowers the blood pressure. Indications, so elevated blood pressure, CHF, stroke prevention, improve myocardial infarction survival, indicated for those with renal impairment without fulminant renal failure, safer than beta blockers, CCBs, and diuretics in endurance athletes. So again, those last four are pretty important to remember, particularly that last comment there. Contraindications, so not safe for use in pregnant individuals, not safe for use if history of renal artery stenosis, and any hypersensitivity or allergy. Risk side effects, so cough, probably the most common that we all see, hyperkalemia, hypotension, dizziness, headache, weakness, rash, metallic taste, and may increase lithium levels. So ARBs block the action of angiotensin II, which is a potent blood vessel constrictor. And so this leads to blood vessel dilation, decreased blood pressure, and decreased cardiac work. Indications include hypertension, prevention of kidney failure in those with hypertension or diabetes, might prevent recurrence of AFib, and used when ACE inhibitors are not tolerated. So where I've seen that most common is when patients develop a cough, where you just switch to an ARB, and a lot of times we see that resolve. Contraindications, so not safe for use in pregnancy due to birth defects, any history of hypersensitivity, any history of renal artery stenosis, and not for use in combination with ACE inhibitors. So other risk side effects, very similar to ACE inhibitors: cough, hyperkalemia, hypotension, dizziness, headache, rash, diarrhea, and metallic taste. Diuretics, so mechanism of action is to increase sodium chloride excretion in the urine. Site of action for hydrochlorothiazide is the distal tubule, and for furosemide or Lasix is the loop segment. Indications, so hypertension, often an initial choice in general population, particularly HCTZ, and indicated for fluid retention. Contraindications in pregnancy, and prohibited use in athletes because it can be used as a masking agent for performance-enhancing drugs during urine tests. This is very important. This for sure will come up along your studying, your practice questions, and likely will be on the exam in some way, shape, or form. So if I highlight one specific thing, it's to remember this, that diuretics are prohibited in athletes because they can be used as masking agents. Risks or side effects, so volume depletion might predispose to dehydration and heat-related illness. Potassium imbalance, so can predispose to hypokalemia. Decreased athletic performance, and might contribute to cardiac events due to dehydration. So beta blockers slow the heart rate by decreasing response to sympathetic input. They decrease contraction of smooth muscle in the peripheral arteries and airways, slow the resting heart rate, decrease cardiac response in exercise, and adverse effect on cardiovascular training. Indications are hypertension, tachycardia, specifically for rate control, slow the heart rate, angina, and post-myocardial infarction, drug of choice. Contraindications, so it might increase asthma symptoms. So if you think about like your albuterol, it's going to be a beta agonist, and so if we have a beta blocker, sometimes that can actually worsen symptoms of asthma. It's a prohibited substance for participation in several sports, such as shooting, archery, powerboating, due to the anti-anxiety effects that it has. Risks or side effects, so depression, fatigue, male impotence, increased wheezing, nightmares, and impaired athlete performance. Take another second just to get a sip of water. So asthma medications, anti-inflammatories such as glucocorticoids, Kellan derivatives, which are often used in children for mild symptoms, anti-leukotrienes, and bronchodilators. So glucocorticoids, mechanism of action, inhaled glucocorticoids upregulate gene expression of anti-inflammatory proteins and downregulate gene expression of pro-inflammatory proteins. It's a treatment of choice for chronic asthma and second-line agent used after rescue inhaler for asthma. Contraindications, any history of hypersensitivity, and should not be used as a rescue agent as it takes 1 to 3 weeks for the full effect of medication. Risks or side effects may lead to chronic use may lead to osteopenia, osteoporosis, thrush, especially in our older population, and hoarseness. So Kellan derivatives, often used in children for mild symptoms, derived from the plant Amyvisnaga. Honestly, I don't know if I remember that coming up anywhere on my studying. Bronchodilators inhibit histamine release from mast cells, and so examples are cromolyn, indicated for those over or equal to 2 years of age, and netochromol, indicated for those over or equal to 6 years of age. Mechanism of action for anti-leukotrienes, so they block leukotriene-induced bronchoconstriction and block leukotriene synthesis, such as xyluton, or receptors of leukotriene, such as montelukast. That's probably the medication that we see most commonly used, montelukast or Singulair. They decrease inflammation and have a rapid onset. Indications, so allergy and asthma symptoms. Contraindications are hypersensitivity, and phenylketonuria should not be used as they contain phenylalanine or aspartame. Risks or side effects, xyluton not approved for children as this requires hepatic testing, runny nose, headache, fever, stomach pain, and diarrhea. Bronchodilators, so mechanism of action is to relax the bronchial smooth muscle and to help decrease mucus secretion. Indications, so inhaled short-acting beta agonists. It's the main rescue medication, first-line treatment for asthma. Oral forms are not approved by the NCAA or the WADA, or World Anti-Doping Agency. Long-acting beta-2 agonists, such as salmeterol, have a 12-hour duration and not used as a rescue or acute medication, and can be associated with increased risk of death associated with asthma. Risks or side effects, so oral medication, clenbuterol, is banned due to its anabolic effects, not an ingredient in any FDA-approved drugs in the U.S. NSAIDs and COX-2 inhibitors, so I know that that kind of is redundant there, but I basically am referring to NSAIDs as our traditional NSAIDs that are non-selective, and then you have your COX-2 inhibitors that are selective or specific for COX-2 inhibition. So they block COX, which reduces prostaglandins, and I believe I added this to my lecture last night. Hopefully it stuck in there. I'll have kind of the COX pathway mapped out and which medications block what. So indications include pain, fever, inflammation, and arthritis. Contraindications, again, hypersensitivity or allergy. Children and adolescents recovering from viral illnesses such as chickenpox or influenza should avoid aspirin due to the risk of Reyes syndrome. Avoid aspirin and conventional NSAIDs if known or high risk of GI ulcers, which I'll kind of go into. This is going to be something important to remember as to how GI ulcers or GI bleeding are factored in and what the mechanism is that those might occur with traditional NSAIDs and aspirin. So risks and side effects. So risks include renal disease, GI bleeding or ulcers, headache, rash, nausea, vomiting. GI protective capacity of COX-2 agents is mitigated by use of aspirin. Again, I'll map this out for you here in a second. And animal studies suggest COX-2 may affect ligament strength. No clinically demonstrated difference in human muscle strength. No evidence to suggest individual superiority for pain might inhibit or maybe individual patient preference. Dose-dependent side effects. Lower doses might provide analgesic effect, and higher doses have more of an anti-inflammatory effect. All right, here we go. It did stay in. So again, conventional NSAIDs block COX-1 and COX-2, so can help with pain and inflammation, but also block prostaglandins in the GI tract, and can lead to renal dysfunction and platelet inhibition, which increases risk for overall bleeding. So if you look at this pathway here, the cell membrane phospholipids, that gets released through any cell damage, so any injury, which will then create inflammation. Your phospholipase is what's blocked by corticosteroids, so it blocks very high up in the stream as far as an anti-inflammatory effect goes. And then you have your arachidonic acid, which takes two pathways. So you have your lipooxygenase pathways, which then leads to leukotrienes, and so that's how you get basically, if you take any anti-leukotriene medication like Montelukast, that's how you can get decreased inflammation, most commonly used more with allergies and asthma. And then you have your COX-1 and COX-2 pathways. So COX-1 is physiologic, COX-2 is inducible. And so your non-selective NSAIDs or traditional NSAIDs like ibuprofen are going to act on both pathways. And if it acts on both pathways, you're going to get that COX-2 inhibition of prostaglandin production at inflammatory sites within macrophages and synoviocytes, which will lead to decreased inflammation, decreased pain, decreased fever. But you're also getting blockage of the COX-1 or the physiologic COX pathway, which does have some protective effects in the stomach, intestine, kidneys, and with platelets. So by inhibiting COX-1, that's where you run into issues with the GI tract and history of gastric ulcers or gastric bleeding. So that's one thing to remember. That's important. I remember that coming up a few times. So you lose some of that mucosal protection. And so it has less to do with the thromboxane. I remember it just coming up on multiple questions. Does it come up because you have an increased risk of bleeding through thromboxane inhibition, or is it the prostaglandins in the GI tract? It's the prostaglandins in the GI tract that provide that mucosal protection. And if you take conventional NSAIDs, might lead to increased risk of GI bleeding or ulcers. So again, if you take a COX-2 selective medication or COX-2 specific medication like celecoxib or meloxicam, you're going to block mostly the prostaglandins at the inflammatory sites, which is really what we want, and you get less of the effect at COX-1. But if you take it with aspirin, you're basically adding in a new inhibition to COX-1, and so it basically mitigates the benefit of using a COX-2 medication. That being said, it's probably better to use a COX-2 anti-inflammatory in someone who is taking aspirin for preventative measures, or if they have any cardiac history that they have to take aspirin. So this is something more for practice. I think that should be important. If you see somebody's on daily aspirin, I might consider switching to a COX-2, even if they say they're taking a traditional NSAID daily that seems to manage their pain, it's probably safer for them to be taking more of a COX-2 selective agent. All right. So COX-2 specific, so celecoxib has decreased GI toxicity, like I mentioned before. There's been mention in a couple spots for increased cardiovascular risks. I haven't found any great studies to show that it significantly increased cardiovascular risks. If somebody has, please let me know. But there's potential for increased cardiovascular risk with use of COX-2 specific agents. COX-2 selective, so like your meloxicam, has decreased GI side effects, unknown cardiovascular risks, and etodolac has a higher COX-2 selectivity. Visco supplementation. So hyaluronic acid is an unbranched high molecular weight polysaccharide. It's distributed throughout the whole body, especially as a major component of synovial fluid and cartilage. Primary role of hyaluronic acid in synovial fluid and cartilage is to maintain the viscoelastic structure and functional characteristics of the articular matrix. I know that's a mouthful. I'll kind of get into the effects that visco supplementation has and why it's beneficial. So mechanism of action, there's multiple. The first is rheological. I had no idea what that word meant when I was studying, and so I had to go in and define it. So rheology is the science of dealing with the deformation and flow of matter. So visco injections, HA injections, have immediate restoration of synovial fluid viscosity and elasticity, maintenance of the increased rheological properties for 3 to 7 days after injection, has an anti-nociceptive effect, and acts as a mechanical sponge or sieve to help with removal from the joint of immune complexes and inflammatory cells. So it also has a biological effect. There's an anti-inflammatory effect, effect on immune cells. So it helps restore hyaluronate synthesis, which provides positive feedback for endogenous hyaluronate synthesis. Effects on cartilage. So we have increased biosynthesis and decreased degradation. Its effects on chondrocytes leads to decreased apoptosis and proliferation increases, and antioxidant effect. Indications, so there's multiple brands, as you guys are probably becoming more and more familiar with each of these brands. So Synvisc, Hyalgan, Supartz, Orthovisc, Euflexa. The differences are based largely on molecular weight and how they're produced. So Euflexa is bacterially derived and Orthovisc is synthetic. All of the rest are derived from rooster combs. So you can see some strength gains demonstrated after viscosupplementation due to pain relief, supported by Cochrane database for knee osteoarthritis and supported by the AMSSM position statement for use of viscosupplements for treatment of knee osteoarthritis. So again, it's a great treatment if you have not realized already through your clinical practice during fellowship. The main limitation obviously is going to be insurance coverage, as we've all kind of seen. Contraindication, so any known allergy, any history of allergy to poultry or eggs, except for those that are non-avian derived, such as Euflexa and Orthovisc. Again, Euflexa being derived bacterially, and Orthovisc is synthesized or synthetic. Risks or side effects include local or systemic reaction, injection site pain, infection, and bleeding. Corticosteroids. So various routes, there's oral, inhaled, injected, topical, and iontophoresis or phonophoresis. Limited efficacy studies, both for acute and chronic conditions. Injection complications include fat pad atrophy and hypopigmentation. Those are going to be the most common that we see. Injection into the tendon is not recommended due to risk of tendon rupture, but paratendon injection is probably safe. Again, we try to limit clinically as much as we inject paratendon for multiple reasons. The primary reason being that there's risk for tendon rupture over time, and so that's why you see a lot of referrals for percutaneous needle tenotomy or consideration of PRP, so we're not just consistently increasing that risk for tendon rupture. There's a theoretical risk of diminished resistance to COVID-19. So this is just a list of common corticosteroids that we see, their dose equivalent, potency, and duration. This may or may not come up as you kind of go along. The ones that we see most often are going to be triamcinolone or Kenalog and methylprednisolone or Depo. As you can see, their potency and duration is intermediate in both cases, and we kind of avoid those with higher potency because they come with a lot more risk factors. So beginning in 2021, corticosteroids are prohibited in competition by WADA, or the World Anti-Doping Agency, if administered orally, rectally, or by IM or IV injection. They are permitted in and out of competition when administered by inhalation, intranasal, ophthalmic, perianal, dermal, or injections into bursa, joints, or the epidural space. General athletic concern. So this is just kind of summarizing general athletic concern for photosensitivity reaction for multiple medications. So you can kind of read through this list. I'm not necessarily just going to read word for word, but there are several medications and combinations of medications that may lead to increased concern for a photosensitivity reaction. I guess this last line is probably the most important, or the last two maybe. Antibiotics, such as tetracyclines, fluoroquinolones, and sulfamethoxazole. And then in female athletes, combined OCPs with topical medicines such as retinoid creams or acne. So, any questions so far? I know it's a mouthful, and it's a lot. No, excellent. All right. So, performance enhancing or potentially performance enhancing agents or drugs. So, PEDs, there's a long history of doping. This kind of goes into more of the historical context. In the late 1800s, we started to notice cycling death due to overdose of performance enhancing drugs. There's been a gradual process in fighting against PEDs. The first list of banned substances by the IOC was in 1967. And then other medications have been added to the list, some as masking agents, again, particularly diuretics. Some of this is important, some's not. So modern Olympics, so amphetamines, later anabolic steroids, both medications previously had military applications. So definition of doping, you have to have two of the three to be affirmative to define doping. So use of substances or methods that artificially increment performance, substances or methods that are harmful to athletes, and substances or methods that are against the spirit of the games. So this is just kind of defining the structure around anti-doping policies and banned substances. So there's multiple organizations involved in determining banned substances, developing rules for testing and setting punishments. So International Olympic Committee had the anti-doping resolution passed in 1962. Banned substance list came out in 1967, and the first testing took place at the Mexico Olympics in 1968. So World Anti-Doping Agency, the idea was developed after 1998 Tour de France. Due to differences in governments and International Cycling Federation, they basically wanted a governing body that could oversee more international competitions because there were subtle variations as you go from country to country or competition to competition. Took over many aspects of anti-doping movement from the IOC after Sydney Olympics in 2000. WADA is based in Montreal, Canada. So the code is a document that provides the framework for anti-doping policies, rules and regulations within sports organizations and among public authorities to harmonize anti-doping policies and ensure standards. So many other leagues or sports have their own anti-doping efforts. So there's various international sports federations, different professional sports leagues like the NFL and MLB and the NCAA. They all have their own anti-doping rules and regulations and their own testing policies and their own banned list of substances. You'll occasionally see some crossover, such as NCAA competition that's international, where sometimes the WADA banned list of substances can be used. But that's where it kind of becomes somewhat of a gray area where which list do you use, how do you test, etc. And so that's why the WADA was founded, is so that you have a general governing body. So categories for PEDs, any substance without approval by government health agency for human use. Substances that are prohibited at all times in and out of competition, prohibited methods in and out of competition, substances in competition, sport-specific prohibition, other agents, and nutritional supplements. So substances that are prohibited at all times in and out of competition are anabolic steroids, peptide hormones, growth factors, or related substances, beta-2 agonists, and I put an asterisk next to that. I'll show you here on the next slide or next couple slides. hormone antagonists and analogs, diuretics, and other masking agents such as plasma expanders. So anabolic steroids initially developed after World War II for emaciated prisoners of war. Soviets started using it athletically and could be used for strength gains, speed, endurance, and healing injury. Initial control started in London in 1974 and was added to the IOC banned list in 1975. WADA list of 2021 includes endogenous anabolic steroids, which again, these are a bunch of long words. You guys can go back through and review this. Not necessarily just going to read them all off to you. So endogenous and exogenous anabolic steroids. So risks, they're implicated in liver disease. There are psychiatric effects such as mood swings and aggression, and overall limited data despite decades of use and abuse. Other prohibited substances such as peptide hormones, growth factors, or related substances. One that you might see the most often is erythropoietin or EPO stimulating agents. Risks, it's most often used in endurance athletes, and it has been implicated in the past for increased cyclist death due to hyperviscosity and thrombosis. Other examples are chorionic gonadotropin and luteinizing hormone in males, insulins, corticotropins, and growth hormones and growth factors. So IGF, platelet-derived growth factor, and vascular endothelial growth factor. So again, beta-2 agonists, there's only 4 inhaled beta-2 agonists that are permitted at all times, albuterol, formoterol, salmeterol, and vilanterol. However, they're only permitted when doses are maintained under a specific threshold, and I have those thresholds listed out here for you. No other beta agonist is allowed regardless of route of administration. Hormone antagonists and analogs such as aromatase inhibitors, SERMs or selective estrogen receptor modulators like tamoxifen, anti-estrogen substances, and myostatin inhibitors. Diuretics, again, Lasix or furosemide, hydrochlorothiazide, and then there's risks for dehydration, electrolyte disturbances, and environmental illness such as heat stroke and heat illness. So again, masking agents are really defined as diuretics and plasma expanders. Basically, they're able to pee out more of the potential performance-enhancing drug, and so they might have a lower amount or concentration in their urine, and so they're banned from use just because they can be used to essentially cheat your way through a drug screening. Prohibited methods in and out of competition, so there's blood doping, and then artificial enhancement of uptake, transport, and delivery of oxygen. So there's multiple ways listed out here. We probably don't come across this a whole lot, but still something to take note of and may come up on the CAQ. Enhancement of oxygen transfer, so chemical and physical manipulation, tampering with samples, IV infusions, except those for legitimate medical reasons. So you can receive an IV infusion of less than 100 milliliters within a 12-hour period if the substance is not prohibited. And IV infusions over 100 milliliters within 12-hour period are prohibited unless administered as part of hospital treatment, surgical procedure, or clinical diagnostic investigation. Sequential withdrawal, manipulation, and reinfusion of whole blood. Gene doping, so this is kind of a newer way of enhancing performance, but it might involve the transfer of nucleic acids or nucleic acid sequences, use of genetically modified cells, or use of agents that alter gene expression, such as peroxisome proliferator, activated receptor gamma. Substances prohibited in competition are stimulants, narcotics, cannabinoids, and glucocorticoids. So stimulants, again, just some history on it. I know I'm running kind of low on time, so I'll kind of skip through this here. But this last portion, somewhat important, phenylpropanolamine and ephedra-containing substances were banned by the DEA in 2004. Other stimulants include modafinil. Developed in France only, modafinil is actually legal in the US. The most common time I see that prescribed is for narcolepsy. Not picked up on urine tests for stimulants. Bupropion, caffeine, phenylephrine, some that are less commonly used, and then synephrine are not considered prohibited. Adrenaline associated with local anesthetic injection is not prohibited, and ephedrine, methylphedrine, and pseudoephedrine are prohibited in competition. Narcotics, prohibited list includes buprenorphine, morphine, hydromorphone, methadone, oxymorphone, fentanyl, oxycodone, and there are several others. Not prohibited is codeine. I think that's one important thing to take note of. You might see that pop up on your question bank or CAQ. Cannabinoids, so they're natural forms such as cannabis, hashish, marijuana, etc. There's synthetic, so the delta-9 THC, and then there's cannabimimetics such as spice, again, prohibited use in competition. Sport-specific prohibitions, so alcohol is prohibited in sports-specific, so archery, aeronautics, automobile, karate, motorcycling, powerboating, and bowling, and then beta blockers as well, so aeronautics, archery, billiards, bobsleigh, etc. There's multiple sports. The takeaway here is that there's multiple sports that have banned use of beta blockers and alcohol, basically for the anti-anxiety effect that you see with it. And it is important to know which sports those are. Again, I would reference this lecture shortly before you guys go into your CAQ, but you'll also find this in your AMSSM review. So other agents, creatine is not prohibited. So phosphocreatine serves as an energy store for ATP in the muscle, mainly used for short, high-intensity exercise, but there are potential complications such as renal dysfunction, liver dysfunction, muscle cramping, and compartment syndrome. Nutritional supplements. So basically, the idea is that you're supplying one or more nutrients purported to be missing from an athlete's diet. It's a lot of unclear benefits or harm. Rationale behind nutritional supplements basically is to just help improve physical state of being or homeostasis. But I always tell athletes to proceed with caution. You don't always know what's in all of your nutritional supplements. And so we'll kind of get into this in a little bit, but I always say to just proceed with caution, and I make sure that they're approved substances if they are taking any supplements. And then you also want to look at the manufacturer as well, and if there's any history of cross-contamination. So there's some banned substances, sometimes again due to contamination. NFL has its own list of banned companies. NCAA, essentially ignorance is no excuse. What you don't know can hurt your eligibility. So again, proceed with caution. And that's probably the main thing from that. So NFL has its banned substance list and steroid policy, banned substance list from the NFLPA with its own rules and regulations. NCAA, based in Indianapolis, has its own banned substance list and banned substance list, NCAA health and safety banned drug classes. WADA is based in Montreal. Again, I just posted the link for the banned substance list here if you ever want to reference it. You can also just Google it. So doping testing with urine, blood, or both in competition begins 12 hours before competition through the end of competition. Out of competition is defined by any time out of competition time frame and includes all prohibited substances not selectively prohibited during competition. So all athletes are required to report their location out of competition using the WADA anti-doping administration and management system. That's something important to remember. I remember that coming up on my studying. So WADA control during the Olympics in competition begins at basically right before the day before competition through the end of competition. So 1 minute before competition starts, and out of competition is any time outside the in-competition period. Procedural issues. So WADA, there's a list of rights that the athlete has, and I have a lot of these listed out. I'm not necessarily just going to read word for word for the sake of time and our own sanity here. But these are important to remember, important things to kind of go back through and review. I do remember, again, this coming up as I was doing my CAQ studying. So rights of the athlete, again, are defined below right here. Responsibilities of the athletes, basically saying that what the athletes are responsible for and what they should be aware of when it comes to anti-doping and drug testing. Again, important to know. see more responsibilities. So testing procedures. This is another example of a long list that you should just know relatively well heading into your exam. What I would highlight from this slide here is that specimen must be 85 milliliters. If there's less than 85, then it has to be discarded. And then your specific gravity has to be greater than 1.005 with a pH between 4.5 and 7.5. And then if you have two specimens, which is typically the case, where they divide it into 60 and 25, so that they can have an initial test and then a confirmatory test. So TUEs, or therapeutic use exemptions, enables use of a prohibited substance by an athlete, and TUE will be granted if an athlete can demonstrate that it's required for treatment of an acute or chronic medical condition that would lead to significant impairment to health if the substance were not used. Prohibited substance is unlikely to result in significant improvement in performance. There's no reasonable therapeutic alternative, and the condition for which the prohibited substance is being used wasn't caused by prior use of a prohibited substance or method. Reason I read all of those off is that they're important. I would definitely know this slide regarding therapeutic use exemptions. Applications online can be submitted 30 days before competition, have a period of validity with expiration, and that depends on the governing body. Substances included in the list of prohibited substances are frequently used to treat medical conditions found in the athletic population, such as insulin. And future trends in doping, so gene manipulation is something that might be becoming more and more common. So it's the non-therapeutic use of cells, genes, or genetic elements to modulate, or modulation of gene expression, having the capacity to enhance athletic performance. Site-specific sequence modifications to affect disease versus gain-of-function expression of exogenous transgenes. Not as much something to know for your CAQ from my standpoint, but something to be aware of for clinical use moving forward, especially if you're getting at the higher level of competition. Risks, so there are risks for treatment-induced leukemia, risk of death. Animal studies have shown that there's other risks, such as lipid metabolism and expression of slow-twitch muscle fibers. You can see some gene manipulation that can help express EPO gene, typically used more with those with endurance athletes. And testing, so WADA prohibited since 2004 for any gene manipulation, and genetic markers may be used to identify perturbed physiological markers. Xenon gas, noble gas prefers not to react with other elements. It boosts the body's production of HIF1A protein and might stimulate EPO production. I do remember this coming up as I was studying. That's why I have it highlighted. Official use was sponsored by the Russian government in 2006, and WADA prohibited in competition and out of competition use in 2012. And that's it. I know it's a mouthful. It's a lot to kind of digest. So again, Sue's kind of referenced this earlier. I'll send this lecture on to her. If you want to look back at this, I highly suggest looking back at it. I would really focus on all the highlighted portions that we have in there. Again, I tried to do my best to keep it relevant to the CAQ and to clinical practice, but the highlighted and italicized portions are things that I either saw when I was studying or that I saw when I actually took the CAQ and went back and edited last year when I gave this lecture. Any questions? No? Excellent. All right. I don't know if Susan's still on. I think she had to go run off and do something. I'm not sure. But if you guys don't have any questions, I'm good from my standpoint, and I think we can end the lecture.